Good morning, everyone, and welcome to this week's clinical meeting. We have three cases today, and hopefully the third person will turn up soon. So the first case will be presented by Medicine 1, Dr. Prabakarn, titled Got a Earful.
Good morning, everyone. I am presenting on behalf of Medicine One. Got an earful. Presenting Mrs. C is a 70-year-old homemaker from Ellur, presented with complaint of running nose for 1 week and left earache and earfulness for 3 days, fever for 2 days, and altered sensorium for 1 day. It presented with the coryza on day 1, and on day 3 she had a left earache, fullness, and tinnitus. On day 4 she had a high-grade fever, and on day 5 she had a left-sided headache and mainly post-auricular pain. On the day of presentation, she was drowsy and her verbal output was decreased, and she was not able to recognize the family members. There were no loss of consciousness, no involuntary movement, no limb weakness, no sensory loss, no vomiting, and no blurring of vision. She had a diabetes for 7 years, dyslipidemia 5 years, systemic hypertension 5 years, and hypothyroidism 5 years. And on examination, her BP was 170/80, and she was tachypneic, tachycardic, and was febrile. On examination, she was drowsy, confused, but was arousable. She was pallor and no ictus clubbing cyanosis, lymphadenopathy, pedal edema. On systemic examination, her CVS, RS, and abdomen examination were unremarkable. Otoscopic examination showed a tympanic membrane is congested with the fluid behind it. And CNS examination, her GCS was 14/15. She was confused, and there were neck stiffness present. Summarizing, she is a 70-year-old lady presented with running nose, followed by left earache and fullness, and then high-grade intermittent fever, and finally had altered sensorium. On examination, she was febrile, tachypneic, tachycardic, drowsy, but arousable, and neck stiffness was present. Clinical diagnosis, we made acute bacterial meningitis, otogenic, and she had anemia. CBC showed a neutrophilic leukocytosis. Electrolyte, her sodium was, she had hyponatremia, and we have done a CSF analysis that showed a counts of 5,000 with polymorphs 80%, and protein was 269 and glucose 85. So we started her on dexamethasone, meropenem, and vancomycin, broad antibiotic cover and MRSA cover. We have done a CT brain that showed a otomastoiditis and mastoid bone erosion, and also possible sigmoid sinus thrombosis, for which we started her on Clexane 60 mg BD. And we have done the culture report have came, and it showed a streptococcus pneumoniae, and it was sensitive to third generation cephalosporin. So we narrowed down the antibiotic to ceftriaxone 2 gram IV QCSH, Qtolech, and dexamethasone. MRI brain we have done because the patient had a sigmoid, possible sigmoid sinus thrombosis. MRI brain showed a subdural emphysema and no sinus thrombosis and no focal neuroparenchymal lesion. So we decreased the dose of Clexane, and we have started on antiepileptic also. CT temporal bone we have done to know whether it is an abscess or cholesteatoma, and it features are suggesting of abscess than a cholesteatoma. And clinical anatomy of otomeningitis, it can spread by three hematogenous route, that is via the bloodstream, or direct extension from the middle ear or inner ear to the meninges. And direct extension can be from the deep mineralized bone during the acute infections, or bone resorption causing by the cholesteatoma or osteotitis, and it can in the middle ear infection can spread to can involve the can go to the hematogenous spread, or it can go intradural. It can go causes intradural abscess or extradural abscess. So clinical decision: does Mrs. C require surgical debridement of mastoiditis? There is a meta. This is a systemic review done in Italy. It is a retrospective multi-center study. The duration of study was 6 years, and they have analyzed 24 studies with 181 patients. That was during the period of 1992 to 2023. There is a cohort there is a multi-center cohort study done in that center with the 15 patients. The clinical presentations were earache, otorias, altered consciousness. Earache was 67% and altered consciousness was 60%. And clinical signs like bulging tympanic membrane seen in 33 patients. And microbiology wise, streptococcus pneumonia is seen in 60% of the patients, and no pathogens were detected in 40% of the patients. And treatment in that center, they have done in that center, they have done for all the patients cortical mastoidectomy. And timing of treatment, surgery was done within 7 days for 73%, within the first 3 days for most of more than half of the patients. Result of systemic reviews. This is not just a systemic review, not a meta-analysis. And in that clinical presentations, headache was seen in 69%, and fever was seen in 53%, altered sensorium 38%. And microbiological wise, in that systemic review also, streptococcus pneumonia most frequently isolated pathogen. Myringotomy was done in 83% of the patients. No major surgery is done for all the patients. So most patient requiring 81% underwent surgery within the first day of admission, within 7 days of admission, and most of them have undergone myringotomy. And this confirmed that antibiotic therapy as the first line of treatment, and surgery is served for the patients who lack of clinical improvement within the 48 hours, or there are presence of complications like intracranial abscess and mastoiditis. This is the studies study done, other studies done. So this is the flow chart for management of otogenic mastoiditis. When a patient presents with the meningitis, when there is a suspicion of air origin, we have to do a CT scan and ENT evaluation. And if there is no evidence of bone erosion and no abscesses, we can start on IV antibiotic. And if they have a mastoid erosions and facial no palsies or suspicion of intracranial abscesses, then we have to do, in addition to IV antibiotic, we have to do MRI brain. And if the MRI brain, if there is a clinical improvement, and we have to assess the patients within 48 hours, clinical improvement is there or not. If the patient have a clinical improvement, then we can continue the medical management. If there is no clinical improvement, then we have to do MRI brain in the patients who initially presented without signs of abscess. And in that, if the MRI brain is showing complications, then the patient has to be taken for the surgery. And clinical, and then in the patients who are in medical treatment, we have to monitor, we have to follow the patients for in the 2 to 4 weeks period. And if there is improvement, we'll continue the treatment. And if there is no improvement, then we can consider ENT reevaluation. Conclusion, the prompt appropriate antibiotic therapy for acute bacterial meningitis, and surgery is indicated if there is no response to antibiotic within the 48 hours or complication arises. And the goal is to source control in the tympanic and mastoid cavities. Back to our patient showed response to IV antibiotics. And as the patient had a subdural empyema, we involved neurosurgeon. They said nil intervention, and they advised to involve ENT. ENT surgeon have done a myringotomy on the day 5, and 3 ml of serous fluid was drained, and she was kept on ciproflox ear drops for 5 days. And after the procedure, there was she complained of decreased hearing in the left side, and with the after the procedure, the symptoms resolved. And we are continuing on ceftriaxone 2 gram IV Q-Tolesh, and the patient is planned for review on 4th of November. So take home messages: otogenic meningitis is the most common cause of meningitis, and Streptococcus pneumonia is the top pathogen, and antibiotic therapy is the mainstay of treatment. And patients who are not responding within 48 hours, or if they have a complication, then surgery is mandated. And early diagnosis and treatment is crucial, and mortality decreases with prompt antibiotics and imaging. Thank you.
Thank you, Prabakarn. Just a couple of questions. No, so the first thing I wanted to ask you is, what is you gave anticoagulation to this patient, right? And why do you think this patient, you thought of a sinus thrombosis? I know the MRI didn't show, but why did you, even if there was a thrombosis, do you think it's sepsis induced or do you think it's a CVT that this patient had?
Mostly sepsis induced.
Okay, so if you think of a sepsis induced thrombosis, would you generally anticoagulate a patient? So ideally, as in theoretically, the answer is yes. But if you look at evidence, there's not much evidence to say that it helps. Okay. Second thing is, I just want to ask you, based on when, I want to appreciate you for the fact that yes, usually what we do is we find that the patient has meningitis, and then you need to look at for sources. How often do we actually go and do a ear examination in somebody who has meningitis? So I think doing the reverse is something that's very important. Here you had the ear infection and that kind of had a direct transmission and the patient developed meningitis. But most of the time when somebody has a pyogenic meningitis, it is mandatory to do examination of the ear, nose, throat, etc. to see if there is any source that could cause direct transmission, especially when you have a typical organism like this patient. Okay. Yep. Any questions?
Subdural empyema.
What is the course of antibiotics you chosen? I mean, how many days did you want to give antibiotics for this patient?
Ma'am, 6 weeks of antibiotics for abscess and corruption.
You're going to give 6 weeks of antibiotics?
Now we are assessing him on 4th of November, ma'am, calling to OPD. Plan is to give for extended duration of antibiotic course.
So, did you want to drain it? That is the other question. You
It was very minimal, ma'am. So
okay. It's very unusual to develop subdural empyema with autogenic source. Usually it starts with the sinus and moves up. Did your patient have seizures?
No seizures, ma'am. Only decreased. She was not able to recognize the family members and she was drowsy on the day of presentation.
Okay, thank you.
Any other questions from anyone? Any other points to make?
Sir, they have done in the center, they have done a cohort study, sir, and they also analyze the data in the PubMed in the year 1990 to 2023, whatever data was there, they collected and reviewed. There were no randomized control trials in that, and they just analyzed the facts and they given the suggestions like mostly the patients require an antibiotics, and if the patient don't have an improvement, then surgery may be mandated, and if they have a in the MRI, if there is a complication, then we have will go ahead with the surgical management. Is the
Just one point. In the future, when you're mentioning the CSF glucose, please mention the concomitant RBS.
Yes, sir.
Also.
It is the sure. Sir.
Sure, sir. You mentioned it. Sorry, I missed it. Then. Yep. Thank you. Let's move on to our next case. The presenter will be Dr.